I'd like to start off by thanking Patrick for inviting me back again. I think I am now the longest running American at this conference. He asked me this year to do a new topic. I've moved from the hepatitis C environment to now hepatitis B, and we'll talk about decompensated cirrhosis. So, as you know, and has been dealt with in the first session, about 250 million people worldwide have hepatitis B. Its highest prevalence is in certain areas, particularly Asia, Sub-Saharan Africa, and Eastern Europe. And in other countries, the highest percentage of patients are immigrants from these high prevalent areas. For example, in the United States, 50% of persons with hepatitis B virus are immigrants. And in the EU, about 25% of patients with immigrants. And these immigrants often are undiagnosed because they lack universal screening, and there are cultural and financial barriers which limits their access to health care. So this is the latest data on the impact of immigration on hepatitis B in the EU, and you can see countries there and the prevalence of the population with hepatitis B who are immigrants, and it goes anywhere from almost 100% of the B patients are immigrants down to a very low number of about 5%, but on average it's about 25% across the EU. So let's talk about our case. This is a patient who's a 45-year-old male who, like many patients with hepatitis B, is an immigrant, in this case from Afghanistan. He came to the United States about 10 years ago, and he was found to have elevated liver enzymes about 5 years later. There is the lack of screening and medical care for many immigrants. He has some metabolic risk factors, hypertension and diabetes, and serologically he was positive for hepatitis B surface antigen, and the titer of the surface antigen was 1,200 units. He was E-antigen negative, E-antibody positive, and had a relatively low value of DNA of also 1,200 units. His ultrasound showed some echogenicity consistent with steatosis, and his FibroScan value was 15 with an elevated CAP value. So here's his laboratory data. His BMI was 30. His transaminases were mildly elevated, although all synthetic function was normal, and therefore his CTP score was 5 with a MELD score of 8. So how do we handle this patient? Well, first, as is mentioned in the earlier session, all patients with hepatitis B and cirrhosis should be treated. The treatment options are TDF, TAF, or entecavir. The dose for entecavir is going to be dependent upon whether they're previously exposed to lamivudine or not, as was also addressed earlier. The major reason for viral breakthrough is really non-response. For breakthrough or non-response is really non-compliance. Resistance is incredibly uncommon with these drugs, and lifelong treatment is required with the goal to prevent flare, which could precipitate decompensation in the patient with cirrhosis. A word about surface antigen titer, particularly in patients with low levels of HBV DNA. The titer of HB surface antigen has been shown to correlate with increasing disease severity, increasing the risk of hepatocellular carcinoma and cirrhosis, and our patient already with cirrhosis, therefore this high surface antigen titer puts him at increased risk for development of liver cancer, all the more reason to make sure he's on a nuke for viral suppression. So we've got our patient on a nuke for viral suppression. How would we now monitor this patient moving forward? Well, we measure serum liver transaminases, liver function, and HBV DNA, and we do this every 3 to 6 months. We measure E-antigen if it's positive. In our case, the patient's E-antigen negative. We do this every 6 to 12 months, depending upon the initial E-antigen status, the HB surface antigen titer, and then changes in liver transaminases and DNA in response to treatment. So if the patient is E-antigen positive, we want to monitor the E's a little bit more frequently because there's a chance of seroconversion. And if the patient didn't have cirrhosis, we could eventually stop therapy once they seroconverted. However, in our patient with cirrhosis who's already E-antigen negative, there's little reason to continue to measure E-antigen and E-antibody. Finally, and of clear importance in a patient with cirrhosis, we want to screen for hepatocellular carcinoma with an ultrasound, with or without alpha-fetoprotein, and we do this every 6 months. So here's our patient who is started on a nuke, and you can see that the patient's liver transaminases were elevated initially here, and they remained elevated during treatment throughout 5 years of follow-up. Now, what would we expect? Even with this low level of HBV DNA, if the liver transaminases were due to that low level of activity, then we would expect the liver transaminases to go down, a typical scenario, as you can see here in the red. Our patient didn't do that. So the lack of biochemical response needs to be figured out. Why is there a lack of biochemical response? Well, there's either persistent viremia due to viral resistance or noncompliance, which is unlikely. And as you can see here, we've measured HBV DNA. It was positive initially, and it's now negative. So the lack of a biochemical response is not due to the lack of virologic response. It's therefore must due to some coexistent underlying liver disease. And this is either non-alcoholic fatty liver disease, which it is in this case, given the echogenicity and the ultrasound suggesting steatosis, and the high CAP score. Or it could be due to other things such as chronic hepatitis B, autoimmune liver disease, and of course we can't forget alcohol. So what happened with this patient? He was initiated on therapy, as we saw. He was undetectable for virus in 3 months, and then over the next 5 years, HBV DNA remained undetectable, but the liver transaminases declined a little bit, but really remained elevated. And then over time, there was a gradual decline in platelet count, albumin, and a gradual rise in bilirubin, INR, and serum creatinine. At 5 years, he developed hepatic encephalopathy, ascites, and then bacterial peritonitis. So clearly, he developed progressive decompensated cirrhosis in a patient with suppressed HBV DNA, but probably progression of underlying fatty liver disease. Here's at 5 years. You can see his baseline data compared to what it is now. His BMI is actually a little bit higher. His transaminases are about the same. His bilirubin has gone from 1 to 2.4. His albumin has dropped a little bit. The sodium has dropped a little bit. The creatinine has increased from 0.9 to 1.9, and the platelet count has dropped a little bit further. The CPT score has gone from 5 to 10, and the MELD score has gone from 8 to 19. So this is clearly a patient who now has decompensated cirrhosis. So when we think about decompensated cirrhosis in a patient with hepatitis B, the decompensation is either due to the hepatitis B or it's not due to the hepatitis B. So this slide and chart shows when decompensation may be due to hepatitis B. And there's two scenarios. One is HBV is unknown, so the patient comes to you, no previous workup, B has not been defined or diagnosed, and the patient is decompensated. Or hepatitis B is known, but maybe it's not being treated, either because the patient can't afford treatment, the patient's non-compliant, or treatment may not have been indicated. Now, what are the things that cause now this decompensation due to hepatitis B? Well, if it's not treated, there can be chronic, progressive, active hepatitis B. There can also be an HBV flare as a result of E-antigen seroconversion, which can occur spontaneously or with therapy. Treatment of hepatitis C, causing hepatitis B to flare. Cancer chemotherapy, altering the immune response. Or treatment of a coexistent immune disorder with high-dose steroids, calcineurin inhibitors, or biologic agents. The flare can also be the result of HBV being treated. So if a patient is not thought to be cirrhotic and is treated with PEG interferon, when this patient with E-antigen positivity seroconverts, they can flare the hepatitis B and decompensate. And that's well known, and that's why we shouldn't use PEG interferon in cirrhotics, or at least use it very carefully. Or we stop the oral antiviral agent, or the patient is non-compliant, and then there's a flare. What is the intervention when hepatitis B is causing the decompensation? Clearly, we need to start the patient on therapy. We start, or if the patient was stopped therapy, we restart oral HBV treatment. We stop the inciting agent. If the patient's on cancer chemotherapy, it needs to be stopped if the B is flaring. We stop the immune suppressive agent, and we stop interferon if that's the cause of the flare. We then monitor the patient, and we consider for transplant if the liver function doesn't improve. So let's show some examples of this. So here's an example of an HBV flare in a patient who is E-antigen, which occurred during E-antigen seroconversion. So at the top, I've given you various markers of hepatitis B, the core antibody, the E-antigen, the surface antigen, the DNA. E-antigen seroconversion can occur spontaneously or in response to PEG interferon therapy. Here you see elevated liver transaminases. Here you see the flare. And you can see that the flare typically occurs after E-antigen is lost. And in some patients, core antibody IgM appears. And if you didn't know this patient had hepatitis B previously, this may look all in the world like an acute hepatitis B with core antibody IgM positivity. E-antibody then appears, and the DNA resolves. The liver enzymes remain elevated and then come down. You can also have reactivation of inactive disease. So then this can be in response to chemotherapy, immune suppression, biologic agents, or stopping DAA treatment. So here is low levels of liver transaminases, absent DNA, and then as a result of altering the immune response by these agents or stopping treatment, bDNA appears, then the liver transaminases flare, and then they come down and you have active hepatitis B again. And again, with the flare, this core IgM can then reappear in some patients. Flares can also occur when we treat hepatitis C and eradicate the virus. So this is a patient that I had in the office that was being treated with a DAA for hepatitis C. Here are the liver transaminases here. Here is the HBV DNA. And you can see initially the C virus level was about log 6.5, but surface antigen was undetectable, but core antibody was positive, surface antibody was negative. The patient was treated with the DAA and came back for follow-up about 4 weeks after treatment was stopped. And at that point, liver transaminase, or at the end of therapy, at 4 weeks, the liver transaminases were already up. And the hepatitis B surface antigen had now seroreverted and went from negative to positive, stayed positive. The liver transaminases reached 1,000. We then started on a nuke regimen, and you can see the HBDNA here come down very nicely, followed by the liver enzymes coming down. Now, hepatitis B decompensation can also occur when it's not due to hepatitis B, and that's the case of our patient here, our case. In this case, you have HBV that's inactive or HBV that is suppressed on treatment. And you can simply have progression of another coexistent liver disease, such as NAFLD or NASH. You can have acute alcoholic hepatitis or just chronic alcohol-induced liver injury. You can have a non-hepatitis B virus, such as C or herpes virus or any other viral agent. And you can have drug-induced liver disease as a result of chemotherapy or the new class of drugs, checkpoint inhibitors, which can cause an autoimmune type of liver disease. Here, the intervention is to continue treating the hepatitis B, or if the hepatitis B is not being treated because they were inactive, to initiate treatment of the hepatitis B because the patient is now decompensated. You want to treat the inciting agent or stop the inciting agent. And clearly, if this patient is not decompensating from B, they're probably not going to get better with the nuke therapy because they're already on the nuke, or we just added it to prevent any further activation of the B. And so clearly this patient would, a patient with decompensates not due to B would clearly need to be considered for liver transplantation. So here's a clinical course. And we're looking at HBV DNA and liver transaminases. The blue is the bilirubin, and down here is the INR and the serum creatinine. So what happens to a clinical course of a patient with HB who decompensates? The DNA is up very high, the liver, which is then followed by a rise in the liver transaminases. The bilirubin then slowly increases, and then there's decompensation with increasing serum creatinine and INR. And the sequence of events of decompensation is a flare in the DNA, followed by a flare in the transaminases, followed by a slow rise in the bilirubin, and then loss of function with INR going up, followed by the serum creatinine going up as a result of decompensated disease. And you can see that right here with slow rises in the INR. And this is what pushes up the MELD score in this patient. Now, if this flare is due to hepatitis B reactivation or due to the virus not being treated and we start treatment, we then truncate this flare. So look at the HBV DNA here that flared up. And now we institute antiviral therapy, and the HBV DNA comes down very nicely. That's then followed by a decline in the liver transaminases, and the bilirubin, which led to the recognition of the flare, peaks and then starts to slowly come down. Importantly, what we've done by adding suppressive therapy for HBV is to blunt the decompensation of liver function and preserve the INR and the serum creatinine. These don't bump up, and as a result, the MELD score is going to remain high, but under a critical value, and then start to improve. And the patient goes on to recovery of this flare. So factors affecting the overall survival of a patient with decompensated hepatitis B include what happens to liver function at the time of the flare, and that's highlighted by the MELD score. If the MELD score is greater than 20, there's a 53% chance of early mortality, compared to only about a 10% chance of mortality if the MELD score remains under 20. Response to antiviral therapy is associated with a lower rate of mortality. And the overall causes of mortality, the number one is that slow rise in creatinine, development of hepatorenal syndrome. So mortality risk, MELD over 20, viral non-response, and developing multiple complications of decompensated liver disease, hepatorenal syndrome, variceal bleeding, sepsis, and hepatic encephalopathy. Overall, from this study by Zhang, mortality associated with decompensated B as a result of a flare was 7%, but 10% of patients required liver transplantation to get through the process. So what happened with our case? He developed SBP, as we said. He was treated with albumin and antibiotics. An ultrasound demonstrated a new mass, which was shown to be liver cancer on an MRI. He was treated with embolic therapy, evaluated for liver transplant, and underwent liver transplant and was given HBIG immediately prior to and immediately after the transplant. Hepatitis B therapy was continued, and on his explant, the liver demonstrated cirrhosis, steatosis, and stained positive for surface antigen. So let's summarize. Many patients with B come from lands far away. If this is not found, then the virus could prey. But if DNA is low and it's inactive, as they say, a low surface antigen may just save the day. All patients with cirrhosis need to be treated, and entecavir, TDF, TAF will not be defeated unless the patient stops taking the med and the Hep B virus awakens from bed. Patients with B and cirrhosis can decompensate. The events that cause this can fill a big plate. Non-treated B can propagate. Treating with PEG interferon can be the bait. Inactive B can reactivate. Liver injury and another cause may yield the same fate, and that's why we treat B before it's too late. If flare and/or decompensation cause the ability to soar, the key is to watch the MELD score. And if the MELD remains less than 20, there is little reason to worry, and the patient is very likely to make a recovery. However, if the MELD is too high and complications of cirrhosis become part of the pie, then the patient is at risk to say goodbye. And we should consider giving liver transplant a try. Thank you very much.